like to, hopefully this will make sense in terms of the order of the presentations, but what I'd like to really focus on is the piece of health technology assessment which is not universally considered a part of health technology assessment, which is sort of what comes before the systematic review and appraisal of evidence. So in this kind of chain of activities, or what Rittingen in his article called the knowledge value chain in the health sector, a slide, by the way, that I borrowed from Dr. Lee's presentation. What you'll see here is that the activities labeled SR, or systematic review and health technology assessment, the synthesis of evidence, follows on to the activity of primary research, or generating primary evidence. And I think historically, but this is changing, the scope and domain of health technology assessment has not considered itself, has not considered it essential to be deeply involved in the production of primary evidence. Again, this is changing, but I want to try to illustrate why that is so important and increasingly understood to be a critical responsibility in the range of things that the health technology assessment community will be increasingly involved in. So first, I think many of you have seen a version of this, and there's many different ways of portraying this, but it's not news to anyone in the room that whenever you go about trying to review existing published evidence, there are huge gaps in knowledge, and this is a summary capturing that from the BMJ, the British Medical Journal's clinical evidence synthesis of evidence. And if you look at the big half of this pie, which is in the gray, that's the percentage of 3,000 treatments for which the effectiveness is unknown. So about half the time when you're going to be looking at treatment effectiveness, you'll have high quality evidence to determine the effectiveness. The other half of the time, not so. I won't go into the details about the fact that this is based on evidence from randomized controlled trials, and you heard Mike Rollins talk about the sort of the perhaps unjustifiable emphasis on that kind of evidence. But in any case, this suggests that there are plenty of gaps in knowledge. And so what I wanted to do was try to illustrate that with a specific case study, and I've borrowed from Mike English, who's been working for many years in Kenya, the case study of the use of hydroxyurea for the management of childhood sickle cell disease in Kenyan county hospitals. I chose an example from a very low-income country because I think it's nice to sort of illustrate that processes for health technology assessment actually don't require huge resources, and they can be done quite skillfully and effectively in this context, and again, don't require huge investments. But very briefly, this case study begins with the burden of illness of sickle cell disease in Kenya. So 312,000 neonates globally born with sickle cell disease. 75% of that burden is in sub-Saharan Africa. The mortality is extremely high in children between the ages of 6 months and 3 years. And again, the mortality rate from sickle cell disease is extremely high, 7.3 per 100 patients, years of observation in Tanzania. So a huge public health problem, dominant in sub-Saharan Africa. The current situation in terms of health technology assessment of sickle cell disease in Kenya, there are clinical guidelines in Kenya recommending supportive care for children with sickle cell disease, and supportive care includes analgesics or painkillers, folic acid, malaria, and penicillin prophylaxis. And then the painful sickle cell crises are managed with hospitalization and blood transfusion. Hydroxyurea is the only currently available agent that's capable of modifying the disease. It's only been studied and approved in adults, but it potentially could be useful and important as an add-on therapy in children. And so just this past year, there was a new systematic review and a clinical guideline that was developed about the use of hydroxyurea in sickle cell disease in children. This is, I'm going to do sort of a quick rundown of some of the results of the systematic review. So if you look, the next 3 slides are sort of looking at different outcomes. So the entire body of evidence looking at the pain episodes in children who received hydroxyurea versus those who received placebo, whether from randomized trials or observational studies, quality of evidence for this outcome was either low or very low. If you look at mortality in children who received hydroxyurea, again from either randomized or retrospective cohort studies, quality of evidence low or very low. And then toxicity, the most significant of which is the hematologic toxicity of reduced absolute neutrophil count from an RCT, identified episodes of mild to moderate neutropenia, but again, a low quality of evidence. So based on this very nicely done systematic review and sort of well-structured summary of evidence, the guideline panel that met this past April in Mombasa came up with the following conclusion, that hydroxyurea should be considered for use in children below 5 years of age with severe sickle cell disease. And for those of you who are familiar with guideline language, should be considered is one of the softer versions of a recommendation. It's not, should be provided. It's, again, reflective of the uncertainty. The recommendation was based on the low quality of evidence that you saw. Importantly, the resource implications of implementing this recommendation would be considerable because there's substantial costs of the drug as well as substantial costs for monitoring the drug counts in patients who are taking hydroxyurea. So here's a case where I think, again, referring back to some of the things that Mike Rollins said, the likelihood of the need for high-quality evidence is probably high given the resource implications of actually providing the service. And then the guideline made a strong case for the need for further evidence on effectiveness and safety of hydroxyurea, including effects on mortality in East African settings, and that this research is urgently required. And so I guess, really the point of this case study was just to highlight the fact that you can conduct extremely high-quality, well-structured systematic reviews, and in a case where the underlying evidence is deficient or defective, it's impossible to come up with the kinds of recommendations that will have an impact on policy that could have huge potential benefits, for the patient populations. And I guess what I would say mainly as the punchline here is that if we choose to think or hope that the evidence generation piece of this is not part of the responsibility of the HTAi community, we'll be continually, struggling with the systematic lack of evidence for important conditions for important research questions like this. And as I'll sort of get to, the fact that 75% of the burden of disease in this particular condition is in sub-Saharan Africa suggests that the traditional sources of funding for clinical research may not prioritize this extremely highly as an area for funding. And so to kind of wrap this up, I wanted to just highlight at least 4 areas that I believe the HTAi community is beginning to and should aggressively become more involved in terms of promoting evidence generation. So, these 4 areas are more reliance on HTAi and more emphasis on priority setting for research, the use of HTAi reports to provide methodologic guidance and advice on exactly how to design the kinds of studies that are necessary to address the identified uncertainties, a critical need for building data and research infrastructure that makes evidence generation more efficient and possible, particularly in in settings that have limited resources. And then, importantly, mechanisms to align payment policy or reimbursement policy or access policy with that actually promotes the evidence development for critical gaps. So, because my time is limited and I don't want to go over, let me just touch quickly on some, sort of points of light or progress in each of these areas. First of all, the Agency for Health Care Research and Quality, AHRQ, in the U.S., has developed an entire new program called their Future Research Needs. And basically what this is a focused effort to turn every health technology assessment report to develop a companion report that identifies what are the important unanswered questions and uncertainties that should be a focus of future funding. We actually participated in one of these through a multi-stakeholder process on the topic of treatment of uterine fibroids. And this was done 2 years ago, and just recently the new Patient-Centered Outcomes Research Institute funded studies to address the top 3 research priorities that were identified through this process. So I think that that's one way clearly in which research priorities identified through health technology assessment can become the portfolio or the agenda for future research. So that's priority setting is critically important, and it's critically important that that priority setting be done with the participation of the key decision makers and the other stakeholders who understand where the needs are for the evidence. Scientific advice and guidance, there's too much on this slide to go into, but basically the notion is the design of studies to address key uncertainties must be done in collaboration with the decision makers. And again, I'm referring back to Mike Rollins' comments, but when Mike talks about getting the methodology right given what the question is, the only way to determine what the right design for a study is to address a particular uncertainty is to actually engage the key stakeholders and decision makers in helping to determine whether it should be an RCT or a registry or some other kind of study. Because the issue of what level of uncertainty is required, what level of certainty is required from a study in order to change policy needs to be a dialogue that occurs with decision makers. And so, for example, in the case of hydroxyurea that I was describing, whether it would require a randomized study to give the adequate certainty of the benefits of hydroxyurea to justify the resource allocation necessary to provide that service is something that can only be determined through dialogue with decision makers. The third area that I talked about is building infrastructure for research, and I think there's lots going on in the UK, in the US, many places in the world to kind of turn the healthcare delivery system itself into a infrastructure for generating evidence. This is talking about a new, what's called the National Institutes of Health Collaboratory, which is a network of integrated delivery systems in the U.S. that are equipping themselves to do large, simple trials on important unanswered questions, even types of questions such as, does morning dosing or nighttime dosing of antihypertensives improve patient outcomes? And then the last point, which I won't go into in great detail, is this whole notion of developing reimbursement policies that are sort of pro-evidence generation, and one of those is what's been referred to as managed entry or coverage with evidence development or access with evidence development, but it's where there is at least temporary reimbursement for promising services in the context of research. And you could imagine this being applied in the case in Kenya, where the study of a study of the impact of hydroxyurea on patients with sickle cell could potentially be done in a context where the clinical services were paid for. So to sort of sum up, there's increasing awareness of the critical role of health technology assessment and evidence generation, a range of promising current and planned activities in these 4 key domains of priority setting, methods development, infrastructure, and adaptive reimbursement. And this is certainly an area where collaborative relationships between the HTAi universe, the research community, and decision makers are essential for this to be able to proceed successfully. So thanks very much, and look forward to the discussion.
Thank you, Sean.